Hey, it's Dr. Centeno, and this is Interventional Orthopedics versus Surgical Orthopedics, a primer for medical directors. I'm the Chief Medical Officer of Regenexx. So what we'll discuss, we'll go over what are orthobiologics, some regulations, what are the problems with orthobiologics, and how does Regenexx solve those problems. We'll go over the evidence base for orthopedic surgery and interventional orthopedics, and we'll get into some detailed cost savings models. So orthobiologics is basically the use of substances to enhance healing or maintenance of orthopedic tissues. You could go back to probably hyaluronic acid as the first attempt at orthobiologics because the goal there was to try to replenish the joint rather than using high-dose steroids, which we now know can hurt joint cartilage. So what are common orthobiologics in use today? The most common by far would be platelet-rich plasma. Then you've got bone marrow concentrate, MFAT or microfragmented adipose tissue, cytokine-enriched plasmas. We're even seeing now providers that are using donor tissues like birth tissues, but those aren't really in this discussion. So orthobiologics regulation. Basically, this follows surgical regulation. As you probably know, surgeries are regulated locally by state medical boards. So I'm in Colorado, that would be the Colorado State Medical Board. So if you take a vein from the leg and put it into the heart during a CABG procedure, that falls under the same surgical procedure exemption, 1271.15b. So it's not federally regulated as a transplant tissue since it's autologous, but it's regulated if you're doing that procedure here in Colorado by the Colorado State Medical Board. PRP and bone marrow concentrate for orthopedic use fall into that same autologous transplant regulation. So they're regulated by the state medical boards. So what are some problems with orthobiologics? Well, autologous PRP and stem cell preps vary widely in content and dose. There's no measurement of dosing. Provider skill varies very, very widely. Protocols used are all over the map. The clinical outcome and complications data is generally not collected. There's very little candidacy information out there, i.e. who's a good candidate, who's a bad candidate. There's no utilization review, and there are no real treatment guidelines. So how does Regenexx address these issues? So one of the big problems is that autologous PRP and stem cell preps vary widely in content and dose. And to get around that, we use standardized PRP and bone marrow concentrate preps at all of our national sites, and that's about 75 sites as of this presentation. We also see there's no measurement of dosing at the bedside, and that's pretty interesting because there's nothing else in medicine where you don't know the dose. Hence, we measure the dose and have dosing guidelines based on the published research at all of our sites. Also, provider skill varies very widely here. We have providers that have been highly trained in this area, which are very few, and providers that really have just taken a weekend course. So we only accept physicians into our network with base MSK orthopedic knowledge and excellent image-guided injection skills. Then they've got to go through additional training that we created that lives in a nonprofit. Then they go through additional Regenexx-specific training. And then they get certified based on pass-fail testing, and we do fail people. So what is interventional orthopedics? I've used this term, and it's important that you understand that it's not simple joint injections. While those are included, that's generally not how this is done. And the reason why what I'm talking about takes so much training is because it's what I just put on the screen there. So for instance, injecting a specific AVN lesion in the femoral head using X-ray guidance, or injecting a torn labrum using ultrasound guidance, or injecting the ACL in the knee using X-ray guidance and making sure you're in both bundles, or injecting the patellar tendon using ultrasound guidance, or the rotator cuff using ultrasound guidance, etc. So we're talking about very difficult to perform, very difficult to learn procedures that can't be done off the shelf, meaning we can't just find providers out there that know how to do this stuff. They have to be trained. So here's an example. This is a X-ray guided injection, both intraosseous and intraarticular. So you can see here a BML, or a bone marrow lesion, which I'm treating with an intraosseous injection with a microtrocar into the patella itself. And then you can see an osteochondral lesion there, which is being treated with an intraarticular injection, and some contrast there. Or, in this case, injecting the ACL as I just talked about. Now, you can't use ultrasound for this. You need to use fluoroscopy, although there are other things you can use ultrasound for. So you can see here the contrast patterns. Now, it takes several months for someone to learn how to do this procedure at a high level. Or injecting the superior labral anchor. This is one where you can use ultrasound in thin patients. You can't in heavy patients, and this was a heavy patient. So you can see the needle coming off from the right there, injecting the superior labral anchor. Another problem out there is that the protocols used are all over the map. You're not going to find two clinics that does PRP in the same way. So we, again, have standardized the injection protocols throughout our clinics, and providers have to certify in 90+ different interventional orthopedics procedures that all use the same protocol from clinic to clinic. In addition, clinical outcome and complications data is just not being collected. Obviously, we've been collecting it since 2005 in a registry, so we've been doing that quite a long time. We're tracking more than 20,000 treated patients going back during that time. And we make this data transparently available online to our patients. We also use it for publications. There's also very little candidacy information, meaning at the end of the day, trying to figure out who's a good candidate from a poor candidate, that knowledge doesn't exist in the general world of physicians doing orthobiologics. However, we mine our registry data to define candidacy. And these guidelines are used network-wide. And as an example, we're also doing some really novel things and looking at the microenvironment in a joint and trying to see if that can determine if you're a good or poor candidate. So a good example of this, if you walk into one of our clinics with severe hip osteoarthritis, you're not going to get treated with bone marrow concentrate. Why? Because the bottom line is bone marrow concentrate doesn't work well in severe hip osteoarthritis. Now, if you walk into our clinic with certain types of severe knee osteoarthritis, our data shows that you are a good candidate for a procedure like this. But if you've got severe hip osteoarthritis, you are not. That's not happening out there in the world of orthobiologics other than in our clinics. In addition, there's no utilization review in orthobiologics. So we require internal pre-auths for all procedures. That's a program that's going into place first quarter of 2020. And the doctor must also code the procedure that's being replaced by what it is he's doing. And then we can provide annual reports for cost savings that are generated out of this pre-auth system. And then finally, there are no guidelines. Now, we took it on ourselves to assemble a group of academics, at least I did, and what we did is we produced the first orthobiologic guidelines on bone marrow concentrate. We took advantage of the fact that we had physicians at all of these academic centers who use PRP and bone marrow concentrate, not in clinical studies, but they're using this clinically day to day to treat their patients. That's every place from Emory to Stanford to Mayo Clinic to Harvard to Cornell. So we got those doctors, those academic physicians, and put them on a Delphi panel to look at bone marrow concentrate and produce guidelines. And here's what they came up with. Using a treatment registry. We've done that since 2005, that you should have candidacy grades. We've just talked about that. That you should use expanded informed consent. You should publish your research. Again, we've been doing that for quite some time. You should have advertising grounded in science, use an IRB for new applications. You should use imaging guidance, which we do. Interestingly enough, what they said is the minimal level of clinical research on bone marrow concentrate evidence before use should be a case series to a comparison trial. That surprised me. I thought they were going to go higher than that, but that's what they concluded. So let's look at comparing evidence and look at this from a self-funded plan perspective. What do you want to add, and why do you want to add it to your self-funded plan? Now, we've always had this concept ever since evidence-based medicine came into practical use that we should have a best evidence synthesis, meaning that if we were to apply a randomized controlled trial standard to orthopedic surgery right now, since 80% of orthopedic surgery isn't supported by RCTs, we'd have to get rid of 80% of it. Obviously, what's being used for orthopedic surgery is a best evidence synthesis, or what's now called a qualitative evidence synthesis, or QES. The steps we're going to use here are to look at what the prevailing level of evidence is for what you currently cover, and then what's the prevailing level of evidence for the new therapy. Now, obviously, a poor health plan addition would be if you had an old therapy with very high levels of evidence that it's effective, and you add a new therapy with very low levels of evidence that it's effective. That's a poor bargain for the health plan and the patients. A good health plan addition would be an old therapy that has moderate levels of evidence that it works, and adding a new therapy that's either at that level or above that level. That makes sense. And what I'm going to show is that orthopedic surgery is about a level 3 on the evidence scale, with quite a bit of evidence showing it doesn't work, and that interventional orthobiologics in many ways has better evidence. So let's look at the evidence for orthopedic surgery. Does orthopedic surgery work? Now, the answer to that question is we really don't know. Why don't we know? For about 80% of elective sports medicine procedures, there are no randomized controlled trials that show that they work. We've got no high-level evidence. And for the other 20% with high-level data, we've got a sham problem. Now, what do I mean by a sham problem? Meaning that we'd all expect that for any therapy, there was a sham or placebo control in the randomized controlled trial. That's not the case for orthopedic surgery work. So basically, we have few RCTs that have a sham or placebo arm. The most common arm or comparator is physical therapy. That's one of the reasons we used physical therapy as a comparator in some of the randomized controlled trials we did, because we wanted to produce studies that were equivalent to what's out there in the orthopedic surgery literature. And for this next part, I came up with this grading scale. Basically, obviously, it's very similar to the evidence scale of level 1 being up here and level 5 being down there. I kind of gave this grades so that a layperson could look at it and understand it better, because it was more similar to a school grade. So if you look at arthroscopic debridement in knee OA, and thankfully this procedure is starting to go out of favor, it gets an F, meaning it's been shown not to work. We've got large RCTs showing it's no better than sham. This is one of the few areas, this and meniscus surgery, where sham studies have been done. Here we have meniscectomy for a meniscus tear. Now this is one your health plans are covering. Absolutely, this is covered by every major health plan in the country right now. But we've got 3 large statistically robust RCTs showing no efficacy versus physical therapy or sham. Total knee arthroplasty. This is a hard one to grade. We have one well-done RCT, but that was just published a couple of years ago on a procedure that's been done for decades. But it showed that the number to treat, or the NTT, for a 15% functional improvement was 5 to 6. So you're amputating 5 or 6 knee joints for every one patient to report a 15% or better functional improvement. And 3 and 4 of the patients at 1 year that ended up in the physical therapy group canceled due to good results with physical therapy. In addition, you would give it an F based on an analysis of 2 government databases that shows that it's not cost effective. Now, what those studies concluded was that if you're grandma who wants to walk around the mall and you can't, knee replacement works pretty well. But if you're a 40 or 50 something that wants to be able to go on a 3-hour hike up a mountain, you're going to be generally dissatisfied with your knee replacement results. And we have no sham control study that's ever been conducted for knee replacement. ACL reconstruction for ACL tear. This is an interesting one because a meta-analysis showed there wasn't much difference between doing the surgery and not doing the surgery. And that's actually changed the protocols in Scandinavia, where they will no longer reconstruct the knee right out of the gate like we do with an ACL tear. They give the patient 6 months to 12 months, and they make the patient demonstrate that they can't get back to sports with physical therapy prior to the consideration of reconstruction. And that means they'll only reconstruct a handful of the cases that we reconstruct. And again, we have no sham control study that's ever been conducted here. Then you've got shoulder rotator cuff repair with decompression or shoulder pain. Again, gets an F, no better than physical therapy. We have shoulder rotator cuff for a full thickness tear. Again, gets an F, no better than physical therapy. And then lumbar fusion for DDD, extremely common, extremely expensive procedure, gets an F for being no better than conservative care, but having a 10 to 24% serious complication rate. So interventional orthopedics. So there are major differences in interventional versus surgical approaches. One is going to be invasiveness, obviously. A image-guided injection is always going to be less invasive than surgery. The rehab is completely different. Most of the rehab for surgery is focused on getting the patient back to their pre-op function. Now that's completely different than what we're talking about with interventional orthopedics, where we don't knock the patient back that far, and we can work on the biomechanical problems that caused their issue. Then you've got complication rates, which are vastly different. I'll show you that the quality of research is better. And then you've got the fact that we take people out of hospitals and hospital surgery centers and move them into the office. And then the fact that we don't have add-on fees for devices and implants, which is what you see with orthopedic surgery. So what's the frequency of orthobiologics use at Regenexx? It's critical that you understand that 80% of what we do on a day-to-day basis is platelet-rich plasma. Only 20% of what we do on a day-to-day basis is bone marrow concentrate or a same-day bone marrow stem cell procedure. So for the most part, we are a PRP network that does a little bit of bone marrow concentrate. So what's the prevailing data on platelet-rich plasma? Where does it fit? Well, these are all randomized controlled trials. Each circle represents a randomized controlled trial here that looked at injection of PRP to treat musculoskeletal issues. Look at the volume of data on NeoA. It's pretty astounding. You've got more than 10 studies with a hyaluronic acid comparator. You've got studies with exercise versus medications versus saline or true sham control versus steroid. Then look at the number of problems where we know that PRP is effective, and that's the blue versus the red here. Knee meniscus tear, hand osteoarthritis, hip osteoarthritis, shoulder, carpal tunnel, epicondylitis, degenerative disc disease, SI joint pain, facet pain, Achilles tendinopathy. So we've got lots of research on PRP at this point because these are all randomized controlled trials that generally don't exist in orthopedic surgery. And PRP was effective in 60 of 66 of those trials. Now, these are meta-analyses on the use of PRP for various things, in this case, knee osteoarthritis. in this case, elbow epicondylitis, and in this case, shoulder rotator cuff injuries. So now let's look at Regenexx grades for what we do with bone marrow concentrate, which again represents about 20% of everything we do, not the 80% that we just discussed with PRP. So we have completed a 48-patient crossover design randomized controlled trial with physical therapy. Again, why did we use a physical therapy comparator? Because that's the identical study design that was used for knee replacement, or TKA. So we weren't going to produce a study that was better than what was out there for knee replacement. And again, knee replacement has never been tested against a sham comparator. This is then just going back historically. A long time ago, we published a very large case series comparing bone marrow concentrate with and without an adipose graft. So that was a comparison trial. Going back even further than that, we published a dosing trial. Now, partial to complete ACL tears, this is almost a complete RCT. The data has been looked at, missing 2 patients to complete this 50-patient trial. Excellent results, again, crossover with physical therapy, because we have no sham controls that have been published for ACL surgical studies. So we use the same study design as was used by the surgeons, and showing very good results in partial to complete ACL tears. Now realize that only about 2/3 of the patients who currently get surgery are a candidate for this procedure. So that means at the end of the day that we have about 1/3 of these patients we can't touch with a 10-foot pole, and that gets back to the candidacy information that the network uses. We're not going to accept a patient with a complete retracted tear. We will take a complete non-retracted tear. And then we've got partial to complete ACL tear information that we published a long time ago, having to do with just MRI follow-up showing significant improvement in MRIs in the patients as a result of treatment. Then we've got a case series of shoulder OA and rotator cuff tears that we published quite some time ago. And then a partial to complete rotator cuff tear study that again is done, just missing a few patients. Excellent results, again, crossover with physical therapy, identical to the surgical studies that have been done that did not show efficacy over physical therapy. These studies do show efficacy over physical therapy. Then we've got a hip OA case series of 196 patients, and basically determined that patients over 55 or with severe hip OA have poor results. So that's based on that, going back to that discussion we just had about the fact that our doctors won't treat a patient with severe hip OA. And then some information we published on treating lumbar disc bulges using a platelet-based treatment. And then finally, our multi-site complications paper, the largest of its kind ever published in orthopedic stem cell use, looking at the safety of over 3,000 procedures over 9 years in multiple body areas with an excellent, much better than surgery safety profile. So we're going to end this with some cost savings models. And it's critical that you understand that to create these models, we looked at the average healthcare Blue Book cost for surgery. And then we did some interesting things, because we basically said we're going to factor in the failure rate of our procedure based on the published results or our registry data. And what we were able to do there was to book extra costs on our side for patients who had failed. So let's say we know, as an example, the failure rate is 25%. That means for 25% of the patients, we're going to book a full surgical cost plus the Regenexx cost in order to make sure that we can compare this head-to-head with surgery, assuming that 100% of those patients that fail are going to go on to surgery. And then we looked at complication rates and costs factored in on both sides. And then we looked at rehab and DME rates and costs factored in on both sides. So for our knee procedure, replacing TKA, the savings is in the low 40% range. And again, realize that this revision cost that you see here on our side is based on the number of patients that failed. So this was based on the fact that about 70% of our patients at 2 years met the MCID for the KSS Knee Society score FXN or function at 2 years. So that means that for 30% of the patients, we booked a knee replacement cost on top of the Regenexx cost. So these are very conservative models. Shoulder rotator cuff tear in the mid 40% range of savings. Again, we booked in procedure failure costs on our side for patients who reported failure. Knee ACL, again, much higher cost savings here based on how we do the procedure, but we are booking in a procedure failure cost on our side. Now, this is a lower procedure failure cost because we've been dialing in the candidacy for this procedure for many years now. So in summary, Regenexx solves the problems inherent in adding orthobiologics to a healthcare plan. We have very little evidence that common orthopedic surgeries are effective. We have mounting evidence that interventional orthopedics and using orthobiologics is effective. And we have cost savings models that are very conservative, meaning that we dinged ourselves up quite a bit on purpose in those cost savings models to make sure that we could exceed what was there. So thanks so much for watching and have a great day.